Hello, welcome to Ask Dr. Sham. In this video I'll be talking you through basic ECG interpretation. If you've not heard of Ask Dr. Sham, it's a community for medical students and students that are interested in clinical medicine such as physician associate and ACP staff. If you're interested in content, high quality content that's going to be useful for yourselves, then please check out AskDrSham.com. In this video we're going to be focusing on ECG interpretation. ECGs often frighten people, especially when it comes to interpreting pathological ECGs. But what I'm hoping to do is, unlike a lot of content online, I'm looking to find a fine balance between really complex ECG text and very basic approaches to understanding the ECG. So by the end of this video, you should feel more confident in understanding what an ECG represents. And the aims that I'd like to, or the objectives of this this tutorial should be that you understand what an ECG is demonstrating, you're able to calculate rate and at least understand what sinus rhythm will look like, and then we'll also move on to look at how we can represent, or what areas of the heart are represented on an ECG. So the way that I'm going to achieve this, I'll talk about what an ECG is, we'll move on to talk about the conductivity around the heart. We'll then move to talk about how to calculate rate, rhythm and timings, and then at the end we'll talk about how an ECG actually represents the heart in a 3D fashion. Okay, so I want you to all think about a time where you have been asked to look at an ECG, or where you could be asked to look at an ECG, and how this tutorial will help you. We're going to try and make it as interactive as possible. That's why I've got my iPad. I'll be pausing at different stages so that you can have a think about what we're doing. So first of all, I'd like you to think about what an ECG is and how you describe it to a patient. So pause the video, answer it, and then I'll give you my answer. So the basic way that I would describe an ECG to a patient would be to say that an ECG is an electrical tracing of the heart, and most patients understand that. If they require more information, then you can divulge into that with them. Now, what I want you to think about is why we do ECGs. So again, pause the video and have a think about this. So there's lots of reasons for why we do an ECG, and it doesn't matter what specialty that you work in, you're going to come across an ECG at some point. But usually speaking, it's to understand the rhythm of the heart. We want to do it in a chest pain workup, especially in the acute setting, and we also do it for presentations such as palpitations, syncope, dizziness, collapsing episodes. It's vital information, and in acute scenarios we do what's called a three-lead ECG, which gives us a very quick understanding of the rhythm of the heart. So first of all, we're going to go through the conductivity of the heart. So if you're aware of how electricity conducts around the heart, then I would take this opportunity to again pause the video, draw out the conductivity pathway or cycle, and then you can compare it to what I'm going to do. And if you are not aware of it, then take this opportunity to kind of join in with what I'm doing. So hopefully, if everything goes correctly, you should be able to see what I'm drawing. So I'm just going to change the color to red, and I'm going to start recording my screen. So what I'd like you to do is draw a section across the heart where you've got the two atria at the top and the two ventricles at the bottom. So it should look something like this, and then you've got the septum down the middle, and then you've got the valves. For the purposes of an ECG, I'd like you all to think about the ECG being 2 chambers rather than 4 chambers. And I know that goes against everything that we already know about the heart, but the reason why it's important is if we think about it being 2 chambers, we know that the atria contract together and the ventricles contract together. So when it's represented on an ECG, it's actually just a single representation of the atria and a single representation of the ventricles. So conductivity around the heart starts at something called the sinoatrial node, also known as the SAN. So that's in it just up here on the right atria wall. Now that's our natural pacemaker. It controls how fast our heart beats, and it also controls the rhythm. So if you have what's called normal sinus rhythm, what that means is that the electrical impulse is actually starting at the sinoatrial node. And what happens is that impulse then spreads across the atria like this, and that causes atrial depolarization. Now, depolarization simply means when muscle contraction takes place after an electrical impulse. Okay, so we get atrial depolarization, and when it's working its way around the atrial muscle, it hits something here called the AVN, or the atrioventricular node. Now, the atrioventricular node is quite impressive because it almost acts as a filter for the electricity. So not all the electricity actually passes quickly through the AV node. It causes a delay, and the reason why this delay is so important for the heart is it allows the ventricles to fill with blood before they depolarize and pump blood around the body or into the lungs. So what happens is, over here we have a delay, and then once that delay, the electricity flows through, it goes through something called the bundle of His, and this is a very rapid sequence now. So it goes all the way through the bundle of His, and then you've got one branch to the right side, and then you've got two branches to the left side, and we'll come to that when we talk about bundle branch block. And then this is essentially electricity passing through all the ventricular muscles, causing ventricular depolarization, and this is through the Purkinje fibers. And what that does is it allows the ventricles to then contract. So you have three stages. Stage 1 is up here at the sinoatrial node, stage 2 is over here at the AVN node, and then stage 3 is here through the bundle of His down the Purkinje fibers and causing ventricular contraction. So that's a very basic understanding of cardiac conductivity, but a lot of what we're going to cover in the next few videos is going to refer back to this, because when we talk about different problems like heart blocks, for example, we're going to talk about the AV node. And then when we talk about broad QRS complexes, we're going to be talking about how electricity is flowing through the ventricular wall. So we're going to now move on to the next part, which is the PQRST. Now, for the PQRST, I will be showing you a demonstration of this on your screens. Now, for this, again, we'd like to make it as interactive as possible, so please join in, pause the video, and what I'd like you to do is separate the PQRST into three sections: the P wave, the QRS, and then the T wave. What I want you to do is think about why or what each area of this ECG rhythm is, what it represents. So what does the P wave show, what's a QRS complex, and what's a T wave, and then I'll give you my answers. Okay, cool. So a P wave represents atrial contraction, so that's when the top contracts. As we said, it's the two together. Then we've got the QRS, so that's where the Q, the R, and the S, so that represents ventricular depolarization, so when the ventricles contract. And then the T wave here, that represents when the ventricles relax. So just by the amplitude of the different signals, you'll see that the P wave is quite small, so we know the atrial muscle is quite thin in comparison to the QRS complex, which is the ventricles, so thick muscle, especially on the left hand side, so you're going to get bigger amplitude. And then you've got the T wave again, which is small, and you could ask at this stage, why don't we see when the atria relax? And that's because it's going to be a very, very small amount of energy, and it's going to be hidden within the QRS complex. Okay, so moving forward. So I know this is going at a really fast pace, so take your time through each area, and hopefully we can get through it together. So now we're going to move on to timing of an ECG. So what I could do is I could spend a lot of time talking about how an ECG records, how quickly the paper moves, but what I'm going to focus on is just learning the key timings that you need to know so that you can apply it to calculating the rate, and in the future calculating different rhythms. So we know that an ECG is made up of what's called large squares and small squares. So I'll show you a picture now. So as you can see on this rhythm strip, you've got large squares and lots of small squares. So I'm going to ask you again to answer the question. So just because I've used green quite a lot, I'm going to change it to a blue pen this time. So what I would like you to do is think about this large square here, which is a big square, and then in between that you can see there's 5 small squares as well. So how long does one big square represent and how much does a small square represent? Again, pause the video, have a think about it, and then I'll give you the answer. Right, so a big square or a large square represents 0.2 seconds, so 200 milliseconds, and a small square represents 0.04 seconds. Okay, the reason why that's important is if we look at how many big squares we have going across the rhythm strip, we can actually calculate how over what period of time this is kind of calculated over. So if it's equal to 0.2 seconds, one big square, then we know that 5 big squares equals a second. So when we come to one of the ways of calculating rate, we can adopt that formula. And then the reason why the small squares are important is when we talk about QRS duration, or whether we talk about PR interval, if you can count the number of small squares and times that by the number of, count the number of small squares and then times that by 0.04, it'll give you the answer as to how long each complex is. And it's really important knowing the durations of the different areas or parts of the complex. Right, so what I'm going to do now is talk about the two ways of calculating rate. So there's an easy method, which is reliable to a degree, but isn't accurate. And then there's the accurate method. And when it comes to your exams, the accurate method is better, because if it's in a regular ECG, then actually using the second approach is going to be better for you, because you're going to get a better understanding of what the rhythm actually is. So the first way is probably my favorite, because I think when you're just looking at an ECG, not for exam's sake, you just want to get to the answer as quickly as possible. So what you do is you take one R wave here and one R wave here. So as we know, QRS means when the ventricles beat. So between 1 R and 2 Rs is 2 beats. So what we do is we calculate the difference between these two. So just for this ECG, you can see it's 1, 2, 3, and then we've got half here and then half there. Okay, so that for me is 4 big squares. So what we do is we take a constant of 300 and then we divide it by the number of Rs between the two, the number of big squares between the two R waves. So this is going to be 4, so that will give us 75 beats per minute. And you can do that for any ECG. So if it's really tacky ECG, then you're going to divide it by 2 or 1, and then you know that you're really going to call for help if it's that quick. But if it's a slower rate, then you can do that. And we'll practice this shortly in a few example ECGs. The second method is looking at 30 big squares. So what you need to do is mark from the beginning of mark at the beginning and then count 30 big squares across and then mark again. Okay, this strip here isn't 30, but I'm just going to purely use it as an example. So if I was to mark, say, here, and I was to mark the second duration here, now this isn't 30 squares, but we're just saying it is, that would represent how many seconds? So that's going to be representing 6 seconds, because we know that 5 big squares equal 1 second, so 30 big squares equals 6 seconds. And when we count, what we then do is we count how many QRS complexes are taking place within each from the beginning to the end. So we know that there's 1, 2, 3, 4, 5. So what we do is we do 5 times, so there's 5 beats in 6 seconds, so if we times that by 10, that's 50 beats in 60 seconds. So then we'll say the rate at that point is 50 beats per minute. Okay, so again, 2 methods. The second method is better because you're counting how many beats are taking place in 6 seconds, and then you're spreading that over 60 seconds by times it by 10. Okay, so now we can do some practicing. The reason why practice is important is it really helps cement some of that knowledge. Okay guys, so this is an example ECG that we can work through together. So on this ECG, I want you to apply both methods. The first method being the 300 divided by the number of squares between R and R, and the second method being counting how many squares there are in 30, how many R's there are in 30 big squares, and then timesing that by 10. Right, so in this video so far we've covered a huge amount of information, and if you feel that it's too much to kind of consolidate, then this is an absolutely fine time to leave the video. And if so, please share the video if you feel that other medical students or students interested in clinical medicine would benefit from what I've gone through today. And that's all I can ask for, really. But if you're interested and you want to do more, I was going to continue by going through how the ECG is actually a 3D image of the heart, and usually we think about it being 2D because it's on a piece of paper, but actually it gives a really good visualization of the heart. So in order to do this, we're going to look at this ECG here, and on this ECG you can see that there is 12 leads. So actually I'm just going to make it a little bit smaller. So as you can see, there's 12 leads on this ECG. Now if I draw a line directly in the middle, these to this side are our limb leads, and these on this side are our chest leads. Okay, so that's really important because limb leads actually give us the ability to look up at the heart and then down at the heart, and the chest leads actually look on it kind of front on. So as you can imagine, the electrodes kind of go onto this area here, so they're looking directly onto the heart itself. Right, so the next thing I'm going to draw is how to understand the different elements of a ECG. So what I do is I would advise that you draw this yourself because it's really useful. So I'm just going to take another colored pen, and this time I'm going to draw a very awkward interpretation of the heart, because as you can tell by now, I'm no artist. And what we have is we have lead 1 here, lead 2 here, lead 3 here, and then we have what's called AVF, and then you have AVR here, and then you have AVL here. Now what I'm going to do is draw arrows towards how each lead is actually looking at the heart. So the key is to remember that 2, 3 and AVF all are looking up at the heart, so they give us information about the inferior surface of the heart. 1 and AVL are what we call high lateral views, so they look to the heart at a lateral aspect. And then we have AVR, which is ultimately looking at the right atrium. Okay, so this is really important. If you can master this, then when you look at an ECG, you'll be able to represent what areas are affected of the heart. And when it comes to myocardial infarctions, for example, this is the way that we will do it. And for your exams, it's often something that you'll see. They'll show you ST elevation and they'll ask you what part of the heart or what type of myocardial infarction it is. Right, moving on, then we need to talk about the chest leads. So chest leads are really easy. If you know how to do an ECG already, then you've already come across how you put the leads on. So essentially it's exactly the same thing, and I apologize for my drawing once again, but if we say that's a kind of transverse section through our chest, we have a vertebra at the back, and the heart will sit something like that. Now you'll have V1 about here, then V2, then V3, and we're going to run out of space, 4, then 5 and 6, like that. Okay, so what each area does is it points at an element of the heart. Okay, so from this we know that from V1 and V2 we're still kind of very much kind of towards the septal right atrium area. V3, V4, V5 we're more anterior, and then kind of V6, V5 and V6 we're looking at it from a lateral perspective. Okay, so this helps again with ECG interpretation. Okay, so the last thing I'm going to do, we've again talked about a lot of information, but what I was hoping to do is take that 3D image that we've talked about and actually implement that onto an ECG. So this is something that I kept really dear to myself during my ECG learning, and it's still something that I remember. What I would advise you all to do is take a ECG and mark out where the different areas or what different areas are represented on a ECG. So we'll do this by using a few different colors. Okay, so the easiest one that I set was the inferior leads. So the inferior leads are essentially 2, 3 and AVF, like that. Okay, so that is, the red represents inferior Okay, so just going to change the color of the pen to blue, and when we're changing the color to blue, we will then note out another very easy area, which is the anterior part. So anterior, so kind of, let's say it's V2, V3 and V4, like that. So that represents the anterior part of the heart. Then we have the lateral. So for the lateral, we'll pick another color, so we'll go green. And if we just block off V4, V5 and V6, that's our lateral leads here. And then we have a few leads which are left, which are a little bit more tricky, because we've got 1 and AVL. So if you remember 1 and AVL, they came on that side onto the left side. So they are this area here. So if we do that like that, that represents kind of a lateral view. And then V1 in itself is a more septal representation of the heart. Okay, so I will include a better impression of this for your own notes. I would advise that you print it off and keep it, because it's, once you understand this, it's really easy to understand where something is happening in the heart, especially when it comes to ST elevation MIs. Okay, so that's everything for this video. We've gone through a lot of information on ECGs. I've tried to do it as quickly as possible, and I hope I've made it as interactive as possible as well. In the next video, we're going to be talking about rhythms. So we're going to start talking about things other than sinus rhythm. So when I mentioned earlier that PQRST, if you see that regularly, you know that it's starting in the sinoatrial node, so that's sinus rhythm. But we're going to move on to things like heart block, so when you've got a problem with the AVN node, and then we'll start to talk about other variations of the ECG, including ST elevation, T-wave inversion, broadening of the QRS complex, and in the final series we're going to talk about other things or other scenarios when we use ECGs and what those pathological ECGs are, including heart blocks and how they should be interpreted as well. So if you found this video interesting, you found that it's helpful and improved your understanding of ECGs, then please share it with your colleagues, because this would really help Ask Dr. Sham grow as a platform. Also, if you have already been on the Ask Dr. Sham website, you would have seen that there's a guide on surviving wards as medical students, and ECG interpretation is something that you can apply to your ward-based teaching. If you go through everyone's notes, you're going to find multiple ECGs. Look at them, look at as many normal ECGs as you can, so that when you actually get to looking at pathological ECGs, you can tell the difference. Thank you very much. I hope you liked it. If you have any comments, give me a shout. So you can find me on LinkedIn at Dr. Sham Mahmood. You can find me on Twitter at Ask Dr. Sham, and you can also email me at askdrsham@gmail.com. Thank you.